Okay, now, Dr. Mazen, please, I allowed you to share your screen to give us very valuable tips about the refractive lens exchange, which is commonly performed. Let's say that it's commonly performed.
You are telling this to me that it is commonly done. Actually, I hate it.
yeah, because it's related to the financial or the money-wise status of the patients. But actually, I disagree. If the patient is unable to do the right one, to wait on the glasses and the contact lenses. Please, sir, start.
Great. Now, clear lens extraction, as you said, it is done. Let's say talk about scientific part, not financial part. So it is done for extreme cases when we cannot do LASIK, when we cannot do or PRK, for example, and when the parameters inside the eye are not suitable for phakic IOL. So in this case, we may go for clear lens extraction and do monovision or mini-monovision. This is one of the solutions, or clear lens extraction and implantation of premium lenses, such as multifocals, trifocals, or EDOF lenses. And the talk about the premium lenses will be similar as if we are talking about cataract surgery and premium lenses. So the workup for clear lens extraction and mini-monovision or monovision, I consider the age, of course. For the age, I don't do clear lens extraction when the patient is below 45. By the way, I don't do the surgery at all, but in general, these are my rules. Not below 45 years old. For the refractive error, it should be done for plus, not for minus, especially if the plus is above 4 diopters and LASIK is not suitable. Regarding the posterior astigmatism should be considered, of course, should be considered for the toric IOL calculation. As I said before, that we have to consider that total corneal refractive power, 3 millimeters, as I showed a slide before. We have to determine the non-dominant eye, and we have to do the tolerance test in the clinic in order to see whether the patient will tolerate a difference of 175 to 1.5, 125, 1 or less, because there are, let's say, a range of difference or monovision and mini-monovision. Some patients may tolerate up to 2 diopters difference. Some patients may tolerate just 0.5 difference. So we have to be sure which difference the patient will be tolerant to. Then we have to study corneal tomography and wavefront. Now, here I have to show you some beautiful slides. First of all, when the cornea is a parabola, when the Q value is minus 0.53, there will be no spherical aberration. So this is called the eagle eye, okay? There will be no spherical aberration at all. When the Q value is more positive, for example, minus 0.2, there will be positive spherical aberrations. And whenever it is more negative, for example, minus 1, there will be negative spherical aberration. Now, the cornea is in the positive side, okay? It ranges between 0 to 0.55, but the average in the average population is plus 0.27, plus minus 1 standard deviation, okay? So this is the average of the positive spherical aberration induced by the cornea, the human cornea. Now, what is the depth of focus? Now, let's assume that this old gentleman is reading a book and he is using glasses and he doesn't have any accommodation. There will be something called the depth of focus, which means that this gentleman can move the book forward and backward within a range, a specific range, and he can still see clearly. We call this depth of focus. So he can still see clearly in spite of not using accommodation, all right? We call this depth of focus. Now, the depth of focus to spherical aberration. When there is no spherical aberration, the image on the retina will be very sharp, and the image in the brain will be very sharp as well. But this has a disadvantage, which is if the object moves, then there will be a severe blurriness of this, the image on the retina and on the brain. That's because there is no spherical aberration. There is no depth of focus, all right? Now, if we say that this patient has some spherical aberration, it means that there will be some blurriness of the image on the retina, but the brain can, let's say, adapt by neural adaptation, and the image can be seen clearly as long as the spherical aberration is within the tolerable range. Now, what is the advantage of this? The advantage is when the object moves backward or forward, the image on the retina will not blur so much, and the image in the brain will stay very clear. Unless the object goes beyond this range, then the image in the brain will start blurring. Now, if the spherical aberration increases, and in this case, of course, the image in the brain will start blurring, and whenever the spherical aberration exceeds the threshold and becomes toxic, then the blurring of vision will be intolerable. Now, let's divide this on the slide that I've just shown you. So we can say that the spherical aberration can be divided or classified into into non-toxic and toxic. It is within the normal range whenever it is between 0 and 0.35 plus or minus. It is non-toxic whenever it is between 0.35 and 0.6, and it is toxic whenever it exceeds 0.6. This is on the positive side, and similarly on the negative side. All right. Now, as I said, the human cornea is on the positive side, but the ocular aberration is not on the positive side, completely just like the human cornea. Why is that? Because the human crystalline lens is in the negative side. So there will be like a compensation, and the resultant ocular spherical aberration is between 0 and plus 0.1 microns at age of 19 years. Why age of 19 years? This is the age of perfect vision. Very sharp vision, okay, but there is no depth of focus. And of course, this young age, they do not need depth of focus because their accommodation is very strong, all right? But with age, the human crystalline lens starts moving to the positive side, which increases the ocular spherical aberration to the positive side, which is a good thing to have because this will increase the depth of focus. Okay, now, what is the relationship between the depth of focus and spherical aberration? When the spherical aberration is 0, there will be no depth of focus. But when the spherical aberration increases, then the depth of focus will increase as well, on the positive and the negative side as well. However, we have to put in mind that the myopic treatment pushes the spherical aberrations towards positive because the cornea becomes oblate, while the hyperopic treatment push the spherical aberration towards negative because the cornea becomes prolate and hyperprolate. All right, but of course, this is not for free. This will affect the quality of vision. the quality of vision is perfect and contrast sensitivity is highest when there is no depth of focus and when the spherical aberration is 0. And the contrast sensitivity will go down with the increase of spherical aberration and therefore the increase of depth of focus. Okay, so we have to put in mind that the hyperopic treatment will increase depth of focus and the myopic treatment will increase depth of focus as well. But the quality of depth of focus and the quality of vision is much better on the negative side. So people having, for example, after hypermetropia, the depth of focus, people, they have depth of focus and quality of vision better than that induced by myopic treatment. By this, I come to this algorithm which I built. I called this algorithm the practical subjective IOL selection, or the PSIS algorithm. Of course, in the market, there are different types of lenses based on the spherical aberrations and based on whether they are premium or not. Now, the spherical IOL, the old or the traditional spherical IOL, it induces positive spherical aberration. There is aspheric IOL with 0 spherical aberration. There is aspheric IOL with negative spherical aberration, and this type has different brand names which they differ by the amount of negative spherical aberration they induce. So because there is no financial interest, I'm not going to mention the brand names and everyone how much spherical aberration it induces, but they are, if you go to the internet, you can find out that. But so we have different, let's say a good range of negative spherical aberration induced by such aspheric IOLs. And of course, we have the premium IOLs, trifocal, multifocal, and EDOF. Okay, so the PSIS algorithm depends on the amount and type of the high order aberrations, the amount and type of the spherical aberration. I mean by the amount, the magnitude, of course, and the type, whether it is positive or negative, in addition to the demands of the patient, the desired depth of focus, whether the patient is interested of having depth of focus or not, or if the patient is interested of having a perfect quality of vision. Because as I said before, depth of focus means less quality of vision and vice versa. So how to start with the PSIS algorithm? Of course, we have to evaluate the high order aberrations and we have to evaluate the spherical aberration. To evaluate the high order aberrations and spherical aberrations, for example, if I have a pentacam, I have to be sure that I am using the maximum diameter 6 millimeter, as you see. I click on the pyramid, I click on the wavefront aberration cornea for the both surfaces, not only, I'm not checking only one surface. And I have to click on the N3, the third order, which includes the vertical and horizontal comma, vertical and horizontal trefoil, in addition to click the N4 M0, which is the spherical aberration. So these 5 high order aberrations are the main aberrations that should be studied. And of course, the computer will show us the RMS of those within the blue ellipse, as you see, the 0.249 in this case. And this one should be 0.35 microns and less to be normal, otherwise it's abnormal. And at the same time, the computer will show us the spherical aberration as an individual high order aberration. In this case, it is 0.242. Okay. Now, if you don't have the pentacam and you have the Cyrus, for example, or the MS39, unfortunately, you cannot click or you cannot make them as a group like in the pentacam. It just shows you the amount of high order aberrations in total from 0 to N6. So it shows the full amount of high order aberrations, not only the third order and the spherical aberration. And it shows you the comma separately. It shows you the spherical aberration separately, and it shows you the residual, which is the trefoil. Okay, now regarding the desired depth of focus and the desired quality of vision, these are subjective things that we have to discuss with the patient before we choose. Now let us start with the PSIS algorithm. If the high order aberrations are normal, it means that they are less than 0.35 microns, equals or less. Then if the patient is interested in depth of focus, it is critical for him, then we have to use premium IOLs because the high order aberrations are normal. But if the patient is interested in sharp quality of vision, then we have to compensate for the spherical aberrations that the cornea has, because don't forget that we are removing the crystalline lens. So the main structure that will affect the ocular ocular spherical aberration is the cornea. So we have to take care of, or to read the corneal high order aberrations and spherical aberration. So we have to use minus or negative spherical aberration if the cornea has positive, and if the cornea is around 0, we can use the 0 spherical aberration. We have to put in mind that our target is to achieve ocular spherical aberration, which is plus 0.1 microns, because it has been found that this will give better quality of vision, better than when the spherical aberration is 0. So the target is like this. For example, if the patient has corneal spherical aberration of 0.3, for example, then I have to implant a negative spherical aberration IOL, which is minus 0.2, in order to achieve plus 0.1 as a target. Now, if the high order aberrations are abnormal on account of other high order aberrations, like on the account of coma, trefoil, and so on, then in this case, I have to use the IOL with 0 spherical aberration. I cannot change the spherical aberration because I'm going to induce more high order aberrations. I have to maintain what the patient has. And if the high order aberrations are abnormal based on on account of the spherical aberration, then I'm going to move to the next slide. So now the patient has abnormal higher order aberrations on the account of abnormal spherical aberration. In this case, if the patient had previous hyperopic laser vision correction, so what do you expect? We expect that the patient has minus spherical aberration because of the prior hyperopic laser vision correction. In this case, if the patient has toxic negative spherical aberration, I have to compensate anyhow. I don't care about whether the patient is interested in depth of focus or not, because they don't tolerate. So in this case, I have to implant the positive spherical aberration, which is the spheric, not aspheric, it is spheric, the traditional spheric lens. Now, if the calibration is negative and not focus, but I have to ask the patient if he is interested in depth of focus, then I have to maintain negative spherical aberration by implanting 0 spherical aberration. Otherwise, if he is interested in image quality rather than depth of focus, I have to compensate for the negative spherical aberration that he has by implanting the positive spherical aberration IOL. Now, if the eye is virgin and the patient has toxic spherical aberration, in this case, of course, I have to compensate, because usually the virgin eye, non-operated eye, the cornea has positive spherical aberration. So I have to compensate, and I have to target to be a plus 0.1, as I mentioned before. Now, if the virgin eye does not have toxic, it has only non-toxic spherical aberration, and the patient is interested in depth of focus, I have to maintain the non-toxic. And if he is interested in quality of vision, in this case, I have to compensate for the positive, by default, to the positive spherical aberration by implanting minus, negative spherical aberration IOL, and don't forget the target. Now, if the patient has a prior myopic laser vision correction, again, if they are toxic, I don't care about what patient's demands. I have to compensate by implanting minus or negative spherical aberration IOL, targeting the plus 0.1 microns. If the spherical aberrations are positive and non-toxic, in this case, I have to consider patient's demands. If the depth of focus is critical, then I have to maintain it. And if the quality of vision is critical, then I have to compensate for it, targeting the plus 0.1 microns. So by this, I come to the number 7, which is specular microscopy, as I mentioned before, no need to repeat. And for the number 8, the sulcus to sulcus, white to white, scleral spot to scleral spot. Now we come to the clear lens extraction and premium IOLs. We have to take care of ocular surface. Of course, as Bonnie said before, that ocular surface is mandatory for all types of refractive surgery, but actually in premium IOLs, special care, we have to do all tests that can detect the severity of dry eye, for example, ocular surface diseases, blepharitis, whatever, because this will affect too much the quality of vision, K readings, measurements, whatever, after the operation. And for the age, clear lens extraction should not be done if the patient age is below 45. For the refractive error, again, it should be reasonable. Now, regarding the pupil, it's very important. This is for the ocular surface disease. Of course, we have to put staining, different types of staining to evaluate the surface. Now, regarding the pupil, there are two issues: the shape of the pupil and the mesopic pupil size. Now, regarding the shape, of course, these shapes are contraindication for premium IOL implantation. If the pupil is very small, if the pupil is very large, so the pupil should be between, the mesopic pupil should be between 2 and 6, not below 2 and not larger than 6 millimeters. Now, this is how we measure the pupil. Usually, I measure the scotopic, mesopic, photopic, and dynamic. It's very important to measure the dynamic as well. Now, the computer will display, of course, this is, let's say it is infrared-based pupillometer. It is built in the MS-39. So it shows me, and in Cyrus as well. It is available in Cyrus. So it shows me the scotopic, mesopic, and photopic. In addition, I have to study the dynamic. I have to study what happens to the pupil movement, whether it is a large movement, whereas there is 0.1 millimeter. So the center of the pupil during the dynamic, it moves just within 0.1 millimeters, which is very good. If it moves larger than this, for example, up to 0.3, 0.4, 0.5 millimeters, then it means that maybe if in the photopic circumstances, then the pupil will be centered with the trifocal or EDOF, the center of the trifocal or the EDOF. But whenever it dilates, the center of the pupil will be shifted, and then this will cause some dysphotopsia. So if the dynamic measurement shows a wide range, then as well this may be a contraindication. I don't have a cutoff value to say that whether it is more than 0.2 or we come to angle kappa should be less than 0.5 meter. Otherwise, this will cause dysphotopsia. Regarding the total corneal refractive power, it is mandatory to take the measurements of K readings and the measurement of the astigmatism by the total corneal refractive power. We cannot depend on the SIM case. And why? Because if we implant, for example, trifocal or EDOF, which are not toric, in cases of more than 0.75 diopters, the patient will suffer from dysphotopsia. So the issue here is not that, okay, there is residual astigmatism and we can treat later. The issue is not residual astigmatism. The issue is the patient will suffer from dysphotopsia. So we have to consider the astigmatism in our treatment. Corneal tomography and wavefront. Of course, we do not implant premium lenses in such cases. I do not implant after myopic. I do not implant after astigmatic treatment. I do not implant after hyperopic treatment. Now, it's very important to consider the high order aberrations, the total high order aberrations, not the spherical aberration here. It is the total high order aberration, which should be less than 0.35 if I'm using the pentacam. But because the Cyrus takes into consideration all order, so we may say that up to 0.4 microns, 45 microns, it can be acceptable. Normal and the correlations. Now look at this case. If we apply the parameters that we all of us use to laser vision correction or not, we will see that everything is fine. Even it may appear that there is superior steep, but if you look at two opposite points, you will is not having high order aberration. So it is not enough to study the topography. We have to see the premium IOLs. Now I can show you some examples. This is a case of normal total on account of spherical aberration, as you see. So if I'm going to do laser vision correction, I can go for optimized. I can put phakic IOL. If I'm putting monofocal, clear lens extraction with monofocal lens, then zero spherical aberration if the patient is interested in depth of focus, or negative spherical aberration IOL if the patient is interested in sharp vision. And I can use the premium IOL as well because the total RMS is normal. This is another example. The patient has high order aberrations. The spherical aberration is very low. So this high order aberration is on account of vertical trefoil and horizontal coma, as you see. So in this case, I look at the symptoms. If the patient is symptomatic, then I have to use the topo-guided or wavefront guided treatment, not the optimized. I can use the phakic IOL, as I said before. If I'm implanting the monofocal, then I must not change the spherical aberration. I don't care about whether the patient is need sharp vision or depth of focus. I have to put zero spherical aberration. And of course, the premium IOLs are contraindicated in such a case. Now, this is another example. The total high order aberration is high. The spherical aberration is moderately abnormal. The vertical trefoil is abnormal. The horizontal trefoil is abnormal. So as you see, there is a mixture of such high order aberrations. And the patient is asymptomatic. In this case, I'm going to use the optimized. I'm not going to change the native high order aberrations of the patient. I can do the optimized laser vision correction. I can put the phakic IOL. If I'm using the monofocal, then the zero spherical aberration, because the spherical aberration is relatively high and I can maintain it to maintain the depth of focus. Otherwise, I have to compensate for it in order to get sharper vision. But trifocal and EDOF are contraindicated. Now, this is another example using the CIRRUS. The total refraction, the total high order aberrations high, the spherical aberration is low. The patient has symptoms. In this case, I have to go for topo-guided or wavefront guided. Phakic IOL are okay. For the monofocal, I have to put 0 spherical aberration. This is example number 5. The high order aberrations are abnormal. The spherical aberration is high. So the abnormal high order aberrations are on account of the spherical aberrations. So in this case, the patient is automatic, so I can use the optimized. I don't change the native spherical aberration of the patient by laser vision. I don't use, the wavefront guided or the topography guided. I can put the phakic IOL. For the monofocal, I consider the demands of the patient. If the patient would like to maintain the depth of focus aberration, otherwise negative spherical aberration. Focal are contraindicated because the total RMS is high. Example number 6, the total high order aberration is 0.52. The spherical aberration is very high. So as you see, it is on account of the spherical aberration symptoms. In this case, I have to go for topo guided or did, and phakic IOL are allowed. Monofocal can be implant. Otherwise, it should be negative spherical aberration. But or the tri are not allowed premium in general because the high order aberrations are high. This is the last example. The total is okay. The spherical is small, and so I will go for sure for the optimized. I can go for the phakic IOL. I can go for the monofocal. 0 spherical aberration to maintain this small amount of the spherical aberration. Otherwise, I can put negative in order to target the plus 0.1 to achieve better or sharper vision. And I can use the premium IOL, and that's it. Thank you very much.
Thank you, sir, Dr. Mazen Sinjab, for this wonderful presentation. It's really very rich and guiding presentation. Actually, the clear lens extraction looked now muchly different with your guidelines. Because the malpractice in the field of the clear lens extraction is usually away from the guidelines, so I hate it or I disagree with it. But if we are following these guidelines, respecting the high order aberrations, respecting the all parameters inside the eye, also respecting the early or the premature presbyopia for that patient, especially in young patients less than 45, it will be helpful for the patient. But let me ask you a last question because of your time. If you have a patient with 45 years old, and this patient is candidate for both clear lens extraction and the ICL, what will you prefer to do?
What is the refraction of the patient?
The refraction minus 12, minus 13 is away from LASIK and film to LASIK and film smile.
Yeah. Well, I know that it is a tricky question. Now, of course, 45, some surgeons, some famous surgeons who I respect, they consider the cutoff age for the phakic IOL or the ICL is 50. So I may follow this, and I will tell the patient maybe after 5 years, you will start developing cataract. I think this is much better than doing the clear lens extraction.